already damaged and prognosis is not good. These are again very important statements through guideline. IgM is often diagnostic of recent infection in case of CMV, often not diagnostic of recent infection in CMV as in rubella. Again, it is confusing. IgM may persist for many months after CMV infection. IgM may be detected during secondary infection also. There may be a cross-reactivity with other infections. IgM may be detected as a result of non-specific polyclonal. That means हम जब बोलते हैं कि IgM है, इसका मतलब recent infection है, जरूरी नहीं CMV में वो सत्य हो. So there are cases when, therefore, CMV specific IgG testing should be performed in parallel with IgM testing along with IgG avidity testing for seropositive, indicating the timing of infection. यदि आप avidity test कराते हैं, then IgG avidity test give you an idea whether the infection is recent or not, because IgM is not diagnostic always for recent infection. In general, a low avidity index is strongly suggestive of recent primary infection with past 3 months, while high avidity index is strongly suggestive of late or secondary infection. Now, how to diagnose cytomegalovirus in fetus? The fetal infection should be diagnosed by detection of CMV cytomegalovirus DNA on PCR analysis जो हम करते हैं, and the amniotic fluid amniocentesis should be delayed again at least 8 weeks after. Suppose mother को बुखार आया, she had a high rise of temperature, glandular fever, हमें दर्द हुआ, then if IgM or IgG low avidity comes positive for cytomegalovirus, don't jump into fetal infection diagnosis. Wait for 8 weeks. Again, after 20 gestational week, you can know. Significant risk factor for false negative results are time interval between infection and amniocentesis. Less than 8 weeks, or gestational age at amniocentesis of less than 18 weeks. Fetal urination develops after 20 weeks. These are the most common findings in cytomegalovirus. You can see these are already I have discussed, and these are by frequency. सबसे common is ventriculomegaly. तो जब भी अल्ट्रासाउंड में BPD में आप lateral ventricle बड़ा देखते हैं, think about cytomegalovirus. जब भी आप ventriculomegaly में साथ में आप lateral ventricle के भीतर ecogenic area देखते हैं, think about cytomegalovirus और viral infection. यदि आप सब ependymal calcification देखते हैं, think about it. Anything which is in brain, like schizencephaly, lesioncephaly, or polymicrocephaly, then you should have an eye think about fetal infection. There might be liver calcification. So these are the features which may happen in this. Already I discussed. This is cerebellum, megacisterna magna, and these are the other ventriculomegaly, germinolatic cyst, agenesis of corpus callosum, intraventricular adhesion, periventricular cystic changes, cerebral calcification, periventricular cyst. These pictures you can get in ISOAG site in their guideline, which you can download and you can have these pictures with you. This may help you to diagnose. These are all, this is synechia, this is again ventriculomegaly. There is a problem with the periventricular cyst, and these features might give you an idea of fetal infection. Again, splenomegaly, there is a pericardial effusion. You can see there is a hydrops fetalis, pericardial effusion. These are the collection of fluid, maybe in parvovirus also, maybe in cytomegalovirus also. This is ultrasound feature of, ऐसा कई बार हमारे ये केस का जो प्लेसेंटा वाले प्लेसेंटा का जो केस था, this case of placentomegaly, placenta might be looking very thick, placental calcification, oligohydramnios and polyhydramnios. Think about CMV, get a diagnosis done by amniocentesis after 20 weeks. This is the flow chart. I'm not going into that detail of proposed management. You can get it in ISOAG site. Again, the toxoplasma is the next. Diagnosis of toxoplasma infection can be made by testing maternal serum, including toxoplasma IgM and IgG. In case of positive or equivocal IgM with negative IgG result, 2 new specimen for IgM IgG antibody testing should be obtained within 2 weeks. That means एक blood test से काम नहीं होता, आपके पास में पेयर्ड 1-2 हफ्ते बाद उसी लैब से फिर से टेस्ट कराइए. If the results remain unchanged, the IgM result probably might be false positive. इसका मतलब ये हुआ कि आप एकदम से स्पायरामाइसिन का ट्रीटमेंट चालू कर देंगे. Looking at the IgM might be a false positive if both the reports are same from the same lab. In case of equivocal results, either IgM or IgG antibody and positive results for the other, a new specimen should be obtained within 2 weeks. If the results remain unchanged, both specimens should be sent to reference laboratory. Women should be informed that high IgG avidity results within first 12 weeks, 16 weeks pregnancy, essentially rules out maternal infection. That means if high avidity IgG के साथ है, प्रेगनेंसी के पहले का इन्फेक्शन है, तो उसमें प्रेगनेंसी का इंडेक्स प्रेगनेंसी में प्रॉब्लम होने का चांस कम है. फिजिशियन शुड बी अवेयर दैट स्पायरामाइसिन ट्रीटमेंट, हम कई लोग स्पायरामाइसिन चालू कर देते हैं. दिस स्पायरामाइसिन में क्रिएट अ डिलेड मैचुरेशन ऑफ IgG एंटीबॉडी, देयरफॉर रिजल्ट इन लोअर एविडिटी. आपको लगेगा कि ये एविडिटी कम है तो रीसेंट इन्फेक्शन है, जबकि ये पुराना इन्फेक्शन का आपने हाई एविडिटी को लो एविडिटी कर दिया बिकॉज ऑफ गिविंग स्पायरामाइसिन. Again, these are all details. As with the other infection diagnosis based on testing, maternal serum IgG, IgM and avidity testing can be useful. IgM testing may not be particularly helpful for timing of infection. It usually appears within 2 weeks of exposure but can persist for years. In case of, ये बता चुका हूं मैं, यदि if you are thinking that toxoplasma in mother has affected fetus, then how to do a fetal infection should be diagnosed by detection of toxoplasma DNA in the amniotic fluid. Amniocentesis should be delayed at least, again here not 8 weeks, at least 4 weeks after maternal infection. Women should be informed that sensitivity of the current molecular method of detecting toxoplasma in the amniotic fluid is less than 90%. So false negative result can occur when the DNA concentration is low. अल्ट्रासाउंड से कैसे पता करते हैं? दिस साइंस सजेस्टिव ऑफ फीटल कॉमनली नॉन स्पेसिफिक, इंक्लूड वेंट्रिकुलोमेगली, ये दूसरे वायरल इन्फेक्शन में भी होता है. इंट्राक्रेनियल ब्लीडिंग, इंट्राक्रेनियल कैल्सिफिकेशन, माइक्रोकेफेली, एसाइटिस, हिपेटोस्प्लीनोमेगली, FGR दैट इज फीटल ग्रोथ रिस्ट्रिक्शन एंड हाइड्रोप्स. मतलब ये जो फीचर्स हैं फीटस के, इन फीचर्स को यदि आप देखोगे तो ये सब के सब आपके फीटस के एंड आर्टराइटिस, मतलब जो कैपिलरीज हैं उनको डैमेज करके देन दे क्रिएट अ area of necrosis and there is loss of cells and there might be ventriculomegaly or intracranial bleeding, intracranial calcification. If these things happen, you should find out these are the toxoplasma fetal. You can see the ventriculomegaly and echogenic thickened ventricular wall. This all are basically when we do target scan or when we do cardiac screening or when we do late ultrasound, third trimester, early third trimester. If these things are there, then think about it that there might be fetal infection and the prognosis should be explained to the couple. The recommendation of parvovirus, given the potential for long-term neurodevelopment sequelae of the parvovirus, the cerebral imaging should be considered for fetus with hydrops or severe anemia. Parvovirus B19 is single-stranded DNA. Pregnant women who have had contact with infected individual who present with the suggestive of rash or who have hydropic fetus should be tested. जब भी hydrops हो और यदि RH incompatibility ना हो, think about parvovirus also because it is common, comes from younger children and this is a communicable thing. If IgM can be false positive, especially in asymptomatic patient, IgM negative results in women with strong suspicion of parvovirus B19 should be complemented with मॉलिकुलर मेथड. अगेन इन फीटस, बच्चे में कैसे पता करेंगे? ऑल्दो द वायरल DNA कैन बी डिटेक्टेड इन amniotic fluid and blood of infected fetus, invasive testing is not indicated unless chordosynthesis is performed anyway for severe fetal anemia. Here amniocentesis doesn't help. It is the chordosynthesis which helps. आपको anemia देखना है. इसमें parvovirus में there is a fetal anemia. The fetal infection can be diagnosed only by invasive testing, usually amniocentesis and occasionally coltosynthesis to obtain fetal blood. Presence of parvovirus DNA during PCR. This is one of the, but think about the platelet deficiency, there might be bleeding, there might be thrombocytopenia. And these are the features, typical hydropic features of parvovirus. How to test? This is the flowchart given in ISWA guideline, and you can go into that guideline. These guidelines you can download through ISWA sites. And how to do fetal anemia testing? These are the middle cerebral artery technique given in that how to identify middle cerebral artery and where to assess. And this is the middle cerebral artery shown in this picture. These you can identify the middle cerebral artery in whole and start when its origin starts, and the peak systolic velocity should be taken, and it should be with Marie's chart, and 1.5 mm se zyada ho to then the baby needs fetal transfusion also. But this fetal transfusion helps in parvovirus because parvovirus का जो infection है वो होके फिर ठीक भी होने लगता है. तो आपने यदि बेबी को support कर दिया उन those places where पे जहाँ पर की fetal transfusion की facility हो, then but definitely hydrops condition is not a very welcome situation for the baby. And these are microphthalmia and cataract might happen. Now comes the rubella. Rubella समझ में नहीं आता मदर को कब हुआ, but it, in contrast to most viral infection during pregnancy, the risk of fetal infection decreases with increasing gestational age. Very important statement. In common with other viral infection, however, the risk of an infected fetus being affected, risk of developing congenital is greatest when infection occur in early pregnancy. So more the early pregnancy affected by rubella, more the chances of fetal rubella syndrome. There are multiple defects in rubella, but when it happens and it is confirmed, then clinician should be aware of high false positive rate of rubella IgM even and interpret result with clinical context. Maternal rubella infection is diagnosed testing by serum level of IgM and IgG. Rubella specific IgG is usually present within a week after onset of rash. IgM level rises, but IgM assay have 5 to. These are given in ISWA guideline. Go through that, and you can see that IgM test alone should also take. केवल उससे काम नहीं होता. You have to take the other things in consideration before giving any positive results. So the maternal with viral testing, rubella IgG avidity can help to give you a identification. How to know the baby is affected or not? Either there will be features in ultrasound or there might be primary infection occurs before 12 weeks. Given the risk of fetal infection and risk of infected fetus developing severe abnormalities, here if you are confirmed, then termination of pregnancy can be considered even without invasive test. Very important statement has been given in ISWA guideline, but it is common that when rubella occurs in early pregnancy, be careful. Amniocentesis performed within 6 weeks of primary maternal infection carries a risk of being false negative. Therefore, a negative result in these circumstances may justify later repeat invasive testing. These are all congenital rubella infection. This happens. Fetal also affected by FGR. But risk of fetal abnormality is greatest when infection occurs before 16 weeks of gestation. This is rubella. Fetus affect हुआ कि नहीं हुआ. The primary infection occurs before 12 weeks. So these again should be taken into account that without invasive testing, advise termination. Viral nucleic acid can be detected in amniotic fluid using PCR. This test has high sensitivity and specificity. Amniocentesis performed within 6 weeks of primary maternal infection carries a risk of being false negative. Already. Now, एक chickenpox होता है pregnancy के समय. That is also very important. The varicella zoster virus is a herpes virus and it is contagious. यदि chickenpox होता है, usually accompanied by fever and malaise, incubation इतना with vesicle फफोले दाने पड़ते हैं And non-immune pregnant should be considered high risk of contracting varicella zoster. For the purpose of counseling, the estimate of risk of congenital varicella syndrome is 0.5% if maternal infection was in the first 13 gestational age weeks, 2% for infection between 13 and pregnant women developing herpes zoster. Again, herpes simplex, varicella zoster, herpes zoster, ये वायरस में herpes zoster और varicella zoster दोनों एक ही वायरस है, बट herpes zoster इज अ लेट वायरस जो कि स्लीपिंग कंडीशन में पड़ा रहता है, बट इसमें यदि herpes होता है तो फीटल हार्म कम होता है. Now again, fetal infection can be confirmed by amniocentesis, diagnosis of fetal infection, and is also worth noting that negative results of following amniocentesis does not completely rule out. Ultrasound features of typical varicella syndrome include microcephaly. Again, you see the brain, microcephaly, hydrocephalus, there might be limb defect, there might be growth retardation and soft tissue calcification. When maternal varicella zoster infection is confirmed before 20 weeks of gestation, fetal varicella syndrome is subsequently identified on ultrasound, and there is a high chance of severely affected baby. In this situation, again, think about termination. More you identify the baby in danger, better to give an idea or think about termination also. This is Zika virus. Disease is considered endemic and traveling to countries जहाँ पर Zika virus होता था. Again, can be diagnosed maternal by RT-PCR. Again, very difficult to identify fetal effect and fetal infection, but head circumference को screening के लिए gestational age देखने के लिए नहीं करना चाहिए, because head circumference might be abnormally low in. So if fetal infection आप सोचते हैं, the HC should not be used at certain gestational age. Following exposure, Zika virus, assessment of fetal anatomy includes the intracellular. Most of the time, the affected area will be brain for viral infection. If during neurosonography, even you do biparental diameter estimation or cerebellum or lateral ventricle, these are all levels by issue of guideline in second trimester. If you think all around them, you might see the features of abnormality. And if you follow correctly the checklist of issue of second trimester guideline, you might get some idea of some problem in fetus. Then you can confirm it by amniocentesis. Thank you very much for patient listening. It was a very complex topic, but it is very interesting and very important for our day-to-day practice. Thanks a lot for patient listening and joining us. Thank you very much.